Everyone, in today's session, we are going to discuss about viral hepatitis D. It is a continuation to the topic epidemiology of communicable diseases in our preventive and social medicine. The types of viral hepatitis. We have viral hepatitis A, B, C, D, and E. Viral hepatitis A to C have been discussed in our previous sessions. You can find the videos in the playlist. Today's video will be focused completely about the viral hepatitis D. Let us quickly brief through the viral hepatitis D. The agent factor is hepatitis D virus, which is a single-stranded RNA which has an envelope from the hepatitis B virus. Let us just see the picture for us to understand. Here, it is a small spherical RNA virus. It has a single-stranded RNA. A single-stranded RNA virus. It is spherical in shape. And the most important aspect is that it has an envelope or a coat. And this envelope or a coat is containing the hepatitis B virion and the antigen, that is hepatitis B surface antigen, is going to provide a coat to the hepatitis D virus. You can see it has an envelope from the hepatitis B virus, and the route of transmission is more prominently the parenteral route. It can affect the any age group, carrier status not present in hepatitis D, and the incubation period is 2 to 12 weeks. It can result in a chronic infection resulting in the cirrhosis and death. Specific prophylaxis include the hepatitis B vaccine. If the hepatitis B vaccine is given, it can act as a prophylaxis against the D virus because its presence is very essential for the survival and replication of HDV. The hepatitis D is classified as the hepatitis delta virus. It is a disease caused by a small circular enveloped RNA virus. Okay, it is a small virus, it is circular and it is having an envelope and it is a single stranded RNA virus. The hepatitis D virus is considered to be a subviral satellite because it can propagate only in the presence of HBV. A subviral satellite means a small dependent viral particle which is depending on a helper virus to its replication. It wants a helper virus that can provide some help for it to replicate. Here, the hepatitis D is a subviral satellite which is depending upon the hepatitis B for its replication. Approximately 15 million people are infected with hepatitis D virus worldwide. The hepatitis B virus infection is more common in adults than children. Basically, it can affect any age group, but the HDV more commonly found in the adults because the route of transmission is parenteral. The drug abusers, those who exchange the needles, syringes, all those people are more commonly the adults, and the requisition of the repeated blood transfusions is also seen in the adults. So the HDV is more commonly found in the adults than the children. Since the parenteral route of transmission, the prominency is more in adults. However, children belonging to the underdeveloped countries are likely to be infected through the breaks in the skin. Okay. So this is the picture of the hepatitis D virus, which is a small circular enveloped virus which is containing the hepatitis B surface antigen in its envelope. Okay. This is the antigen, delta antigen, and it is a single stranded RNA virus containing the envelope of hepatitis B surface antigen. Moving further to the geographical distribution of hepatitis D virus infection. It is estimated that globally 5% of HBs AG positive people will be co infected with HDV. So the co-infection is seen HBV, okay? People infected with HBV are co-infected with HDV. So the co-infection means at the same time both the virus are going to attack the body and they are going to develop the co-infection with HBV and HDV. Globally, 5% are co infected, and the distribution is resulting in a total of 15 to 20 million people infected with HDV worldwide. Okay, 15 to 20 million are infected with HDV worldwide. Then we have the high prevalence areas and the low prevalence areas. The high prevalence areas are going to include the Mediterranean, Middle East, Pakistan, Central and Northern Asia, Japan, Greenland, Taiwan, some parts of Africa, Amazon basin, and certain areas of Pacific as well. And the prevalence low, okay, you can see the low green, orange, and cream. So the low prevalence areas is going to include the Northern America, Northern Europe, South Africa, and the Eastern Asia. Moving further to the epidemiological determinants. This is one of the most important aspects from your examination point of view. We need to be very clear with this. So the agent factor again comes the hepatitis D virus, which is a virion-like particle consisting of a coat of hepatitis B virus. We see that it is a single-stranded RNA virus containing the delta antigen and it has an envelope or a coat of hepatitis B surface antigen. HDV is small spherical particle measuring about 30 to 40 nanometer in diameter. You can see 35 to 40 or 30 to 40 nanometer in diameter. It is composed of a small single-stranded RNA genome which is surrounded by the delta antigen that is forming a nucleocapsid. You can see the delta antigen which is forming a nucleocapsid. The host factor are the humans. Humans are those which are infected with HDV. Moving further to the incubation period, it is 2 to 12 weeks. The reservoir of infection are the humans. The mode of transmission, I told you it is parenteral. What you have to have in your mind is the route of transmission is parenteral. So the virus is transmitted by the same method as HBV, which is again parenteral, vertical transmission, sexual transmission, but more prominently it is parenteral. So the exposure to the blood and the serous body fluids will result in the transmission. What do you mean by exposure to blood and serous body fluid? If a person is infected with HBV plus HDV, then the co-infection could be there, or the person can be super infected. These people, if their blood is transfused to a healthy individual without screening, or there is an exposure to their blood through the cuts or the abrasions, they can result in the transmission. The contaminated needles, syringes, okay, in the drug abusers, if they share the needles and the syringes, also in the healthcare setups, if there is a use of the contaminated needles and syringes, it can result in the transmission of HDV. And also the transfusion of the unscreened blood and plasma products transfusion. Sexual transmission may occur, but it is less common compared to the hepatitis B virus. And also the vertical transmission from the mother to baby may also occur, but it is also less common or it is uncommon. The most important thing you need to remember is exposure to blood of an infected individual, exposure to the serous body fluids of an infected individual, and the use of contaminated needles, syringes, blood, and plasma products transfusions which is unscreened. Mother to baby transmission is uncommon. The risk factors, we have certain idea now. What are the risk factors? These include the homosexual men, mother to child, which is uncommon, and then we have the most important is the sharing of the needles, piercing, tattooing. All of these will increase the risk of transmission of the blood and the contaminated needles with the contaminated blood of an infected individual. And we have needle stick injuries which can occur in the healthcare professionals as well, increasing the risk of transmission of HDV. Moving further to the pathogenesis. The pathogenesis include the co-infection and superinfection. What do you mean by co-infection? Co-infection occurs in 5% of the cases where delta antigen, that is HDV, and the hepatitis B virus are transmitted together at the same time in a healthy individual. Okay, what you have to remember in co is same time. Co-infection occurs at the same time. HBV and HDV occurring at the same time in a healthy person. So what happens in HDV and HBV occurring together in a healthy person? So, the co-infection in the majority of the cases will result in the recovery and the patient develops the immunity against these viruses in the majority of the cases. Whereas infrequently, the person can end up in a fulminant hepatitis. What do you mean by fulminant hepatitis? Fulminant means a sudden plus or very severe hepatitis. These sudden and severe hepatitis can result in death. Whereas in a healthy person, rarely the chronic HBV and HDV infection results in cirrhosis. Is it clear? So if the HBV and HDV persist for a very long time in the body, it will turn out to be a chronic HBV and HDV causing the cirrhosis of the liver. Okay, this is the healthy liver, and now the person has developed the cirrhosis of the liver, but it occurs very rarely. Moving further to the superinfection. Superinfection is seen in 80% of the cases. The delta infection occurs in a person who is already harboring the HBV. So imagine a person is already having the HBV infection. Now the HDV is super added to the HBV. So let us see what happens. In the majority of the cases, in a person who is already harboring HBV gets infected with HDV, then what happens? He starts developing the cirrhosis of the liver. Infrequently, it can result in acute severe hepatitis, but this acute infection resolves on its own and it will help in the recovery of an individual. Rarely, it can result in fulminant hepatitis leading to the death. So, this is the hepatitis B surface antigen which is already present in the individual. Now, he is being super added with the HDV. Is it clear? In a super added infection, what happens? Majority, it results in cirrhosis, infrequent recovery, and rarely death. Okay, majority, it is cirrhosis. Whereas in the co-infection, in the majority, they will cause recovery. Rarely there is cirrhosis. Is it clear? The outcomes, you need to be very clear with it. In the majority, if there is co-infection, it will result in recovery, infrequently death, and rarely there is cirrhosis. Whereas in superinfection, in the majority, it will cause cirrhosis and rarely there is death. Moving further to the clinical features. Infection is dependent upon the HBV for its replication, as the HBV is providing its surface antigen envelope for the HDV. Some of the symptoms exhibited are yellowing of the skin and the eyes. So the patient presents with jaundice. When the liver is damaged by the hepatitis B, it cannot process the bilirubin, leading to its accumulation in the blood, and this leads to the yellowing of the skin and the eyes because of the high levels of bilirubin in the bloodstream. Then the patient can present with dark urine alongside the jaundice. So why is there a dark urine? When the liver is damaged, what happens? The liver will not be able to process the bilirubin. As a result, the bilirubin is getting accumulated in the blood. And since the conjugated bilirubin is water soluble, it is allowed to be excreted through the kidneys, making the urine to appear darker in color, described as a tea color or coca color urine, which is nothing but the bilirubin urea. Let me just write it down for you. What's happening? The liver, the hepatocytes are damaged. They are no longer able to process the bilirubin. Since the bilirubin is accumulated in the bloodstream, and the liver is not able to process it, so the blood is containing high levels of conjugated bilirubin, and the kidneys are filtering the blood. Since the conjugated bilirubin is water soluble, it gets absorbed and it is excreted by the kidneys in the form of the urine, and the urine is containing the high levels of the bilirubin known as bilirubin urea, and this gives a urine a very dark color. Next, we have light colored stools. Again, there is a damage to the liver, the hepatocytes not functioning properly, not secreting the bilirubin to the intestines. There is impaired secretion of the bilirubin, which is required for the absorption of the food. So, the inadequate secretion of the bilirubin into the intestines as a part of the bile is resulting in the experiencing of the pale colored stools. Moving further, the patient also presents with nausea and vomiting. These are very common symptoms in all the viral hepatitis, including the hepatitis D, because the virus has completely damaging the liver, so it is responsible for producing the bile necessary for the proper digestion, for the proper absorption. Since now the bile production is impaired, the intestines are struggling to absorb the nutrients from the blood. So this is leading to nausea and vomiting. Let me again draw it for you. So there is impaired bile secretion into the intestines, okay? And the intestines are no longer able to absorb the blood, okay? Absorb the nutrients. The intestines are not able to absorb. As a result, what happens? There is nausea and vomiting. The patient also presents with the loss of appetite, and since there is frequent vomiting, there can be extreme fatigue. And the patient also presents with abdominal pain, especially in the right upper quadrant. And the bilirubin increased levels can also result in pruritus and rashes. Patient also presents with muscle and joint pain. So this muscle and joint pain can be attributed to the autoimmunity. When the body is trying to fight the hepatitis D viruses, it starts producing antibodies. Sometimes these antibodies will go and cross react with the joint tissues, resulting in inflammation and pain. Then the patient also presents with fever. Moving further to the diagnosis. To diagnose the hepatitis D, we have the immunofluorescence. So the delta antigen is primarily expressed in the liver cell nuclei. And these delta antigens, which are found in the liver cells nuclei, are demonstrated with immunofluorescence. So what is immunofluorescence? It is a technique where we diagnose the hepatitis D wherein a liver biopsy sample is taken, prepared on a slide. It is stained with the antibody against the delta antigen and conjugated with a fluorescent dye. It is observed under the fluorescence microscope. The presence of fluorescent staining within the liver cell nuclei will indicate a positive result to HDV, and it is primarily expressed in the nuclei of infected hepatocytes. Let me write it down for you. I hope you have got some understanding about the immunofluorescence. So that you don't forget about the diagnosis, I go a little deeper, as something I throw some more light upon the words so that it lasts for a long time in our memory. So what happens? A sample, a liver biopsy is taken, a slide is prepared, and on the slide, what are they doing? They are going to prepare the slide by staining it with hepatitis specific antibody, okay, specific antibody against the hepatitis D antigen, and this antibody is conjugated with a fluorescence dye, and then they observe it under the microscope. On observing under the microscope, if the staining is present, it shows a positive result. If there is no staining, it means it is negative. We have anti-delta antibodies appearing in the serum, and these can be identified by enzyme-linked immunosorbent assay. IgM antibody will appear after 2 to 3 weeks in acute delta infection, and these IgM antibodies are soon replaced by IgG antibodies. You need to be very clear with this, since we have discussed about it in the previous slides as well. In an acute infection, the IgM antibodies play a role. Soon, when the infection turns to be a chronic one, these IgM antibodies are replaced by IgG. The blood test will show the elevated liver enzymes. There is an increased SGOT, SGPT levels. Moving further to the complications, we have discussed earlier that it can result in chronic infection causing the cirrhosis of the liver. So whenever there is inflammation, there is fibrosis, the scarring of the liver resulting in cirrhosis. Further, there is liver cancer. So, the chronic injury to the liver over many years is resulting in the cirrhosis of the liver. Now, the damaged liver cells will start to multiply out of control, leading to the development of hepatocellular carcinoma. And also we discussed about the autoimmune manifestations, where the hepatitis D virus antigen instead of destroying the HDV viron, sometimes the cross reaction can occur and the antibodies can start to damage our own body tissues, muscles, joints, resulting in the autoimmune manifestations. The prognosis is a person with acute HDV will get better over 2 to 3 weeks. About 10% of those people who are infected may develop a long-term liver inflammation, which is a chronic infection. Moving further to the prevention. Hepatitis B vaccination will prevent the infection with hepatitis D. Any open sores, cuts, or abrasions, they should be covered with the waterproof dressings. And also encourage the individuals to practice safe sex. And also educate the patients about the safe injecting, safe sex, and screen the blood before the transfusion. And also take body fluid precautions from an infected person. Also, the injecting drug users should never share their injecting equipments. Moving further to the management, encourage the people to take a proper adequate rest. The infected individual should include a healthy diet and avoid risk factors. So with this, we come to an end of this session of hepatitis D. I hope all of the points are clear. If you have any doubts, put them down in the comment section. And if you like the video, don't forget to hit the like button and subscribe.